Good afternoon and welcome to our Orthopedic and Sports Medicine Lecture Series. I am Dr. Rogelio E. Ribas, Corporate Vice President of Baptist Health International, and it's my pleasure to welcome all of you to this informative presentation. I would like to extend our warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A features located in the bottom of your screen. I will also be the moderator for today's presentation. This afternoon, I have the pleasure of introducing Dr. Frantz Lerebours. His presentation is titled Management of Rotator Cuff Tears. Dr. Frantz Lerebours is an orthopedic surgeon at Baptist Health Orthopedic Care. He has an expertise in a wide range of surgical procedures, including complex shoulder and knee ligament reconstruction, rotator cuff repairs, and shoulder replacement surgery. He utilizes patent-specific technology combined with artificial intelligence and 3D printing to improve the accuracy of shoulder replacement and resurfacing surgery. He also has a background in orthopedic trauma and fracture surgery. Dr. Lerebours earned his medical degree at the Harvard University College of Medicine in Washington, D.C., where he graduated with top honors. He completed his orthopedic surgery residency at the New York University Hospital for Joint Diseases, where he served as executive chief resident and was inducted into the Alpha Omega Alpha Honor Medical Society. He then went on to complete a sports medicine fellowship at the renowned Kerlan Jobe Orthopedic Clinic in Los Angeles. Prior to joining Baptist Health Orthopedic Care, Dr. Lerebours was an attending physician at Cedars-Sinai Medical Center in Los Angeles. During that time, Dr. Lerebours provided sports medicine team coverage for the Los Angeles Lakers, Los Angeles Dodgers, Los Angeles Kings. Dr. Lerebours currently serves as a team physician for the Miami Heat and Florida International University Athletics, and as well a consultant for Inter Miami Soccer. Dr. Lerebours has been honored with numerous awards, including the Southern California Super Doctors Rising Stars Award, the Ralph and Phyllis Luskin Resident Teaching Award, the Castle Connolly Top Doctor Award, America's Top Doctor Award, and the Charles E. Epps Award for Excellence in Orthopedic Care. His research has been published in peer-reviewed publications, including Operative Techniques in Sports Medicine and the American Journal of Sports Medicine. He has also contributed to medical textbooks. Please, let's give a warm welcome to Dr. Frantz Lerebours. Doctor?
Thank you so much, Dr. Ribas. I appreciate the introduction. Let me go ahead and share my screen. Okay. So today, I'd like to, first of all, I want to thank everybody for joining us on this webinar today. Today, we're going to talk a little bit about management of rotator cuff tears and how things have evolved even in the last probably 15 years and how we treat these and how this has affected essentially the outcome of these repairs. So first, I want to kind of show you guys this video. So this is essentially what we see when we place a camera in the shoulder. So we're in the subacromial space, and what you can see here, as you see, there's a full thickness tear of the rotator cuff. To your left is the tendon, and on the right, you can see this instrument is being used to essentially debride and remove any tissue from the actual rotator cuff footprint. And what I'm doing here is I'm grabbing the tendon and I'm seeing how much excursion it has and getting prepared to essentially reduce or bring that tendon back down to its footprint and essentially plan where I want to place the tendon. So what is the rotator cuff? So it's essentially exactly what it sounds like. The rotator cuff is a group of tendons. It's made up of 4 tendons: the supraspinatus, infraspinatus, subscapularis, as well as the teres minor tendon. Okay, what it does, it basically forms a cuff around the proximal humerus, and depending on where those tendons attach, helps move the arm in space. The rotator cuff is very important structure in the shoulder because of the half circumferential coverage of the ball. There's important dynamics that take place that essentially balance how the humeral head sits in the socket. And they refer to this balance as something called the dynamic force couples. Okay, so you can imagine the tendons themselves, as they are attached to the ball, they are balancing each other to keep the ball well centered. When you have a tear of one of those tendons, essentially that almost destabilizes the shoulder, and now there's abnormal movement and abnormal kinematics, and the shoulder starts to move in abnormal directions, and that abnormal balance results in abnormal contact. Okay, and abnormal contact, the humeral head itself starts to basically rub on the undersurface of the acromion, and that's what essentially causes much of the pain when you have a rotator cuff tear. Okay, so just like we talked about, okay, the rotator cuff has muscles have three primary functions. Okay, they're involved in rotation of the humerus. The shoulder itself is the most flexible joint in the body, and that has to do with the fact that there's not as much of a male-female fit like, let's say, the hip. There's not as much bony conformity. Okay, so as a result of that, we really do rely on those tendons to keep that keep the humeral head, the ball, seated in the socket. Okay, and then there's the compression aspect of it. Okay, the actual group of tendons itself causes compression into the humeral head. And then we talked about that balance, okay, the balanced force couples. So the rotator cuff is a very common source of shoulder pain and weakness. We'll talk about the actual prevalence shortly. After you get over a certain age, the incidence of rotator cuff tears increases dramatically, okay? And they can occur from both traumatic injuries, the patient falls off a ladder, gets hit by a car, or they can happen slowly over time. We typically see this more commonly where you have slow degeneration, okay, which we see in our more elderly population. So treatment can be both non-operative as well as operative, and this all depends on the chronicity of symptoms, the severity of the tear, the patient's age, as well as their activity level and their actual demand. So people ask me all the time. They come to the office and we start initially treating the patients conservatively. And they ask, if I have a tear, will it just heal over time? And the answer is no. Majority of the patients, even if you have a tear, and even if you become asymptomatic in the future, if we were to MRI you in the future, it would still show that tear. The goal of non-operative treatment really is to decrease pain and inflammation, improve strength, with the hopes of resolving function. So in terms of prognosis, one thing to note for patients is that patients with cuff tears, even if you get them to a place of being asymptomatic, unfortunately, typically they do decompensate over time. Typically after about 2 to 3 years, almost 50% of them end up being symptomatic again. So that's one of the challenges that we face in treating many of these non-operatively, is that they tend to come back. And one of the reasons is that the tear either propagates, it gets bigger and further destabilizes again, or the inflammation just comes back because of the abnormal movement, results in impingement and contact, resulting in inflammation. So again, the factors that we talked about earlier, traumatic versus degenerative tears. Okay, so in terms of symptoms, one of the most common symptoms that we see is night pain. Patients will come in, they'll say that I have pain at night, usually about 2 to 3 in the morning. The pain typically peaks, it keeps them up at night. They'll describe a difficulty or catching motion over the shoulder. Typically, you'll see in the exam room, the patients will lift their arm up and they'll kind of slowly lift it up, and on the way down, they'll start to kind of circumvent their shoulder as they're starting to bring their shoulder down. And one of the reasons is because of that abnormal contact, the lack of the balanced force couples. The shoulder's just moving abnormally. So as they're decelerating, bringing the arm down, they're trying to avoid the shoulder from catching on the undersurface of the acromion. Typically, you also want to check their range of motion. They'll typically lose active range of motion compared to the contralateral side. And then they'll have also weakness and inability to raise their arm overhead, depending on the size of the tear. So treatment, okay, so this kind of treatment algorithm. So non-traumatic degenerative cuff tears can be treated conservatively. Typically, the traumatic cuff tears, so let's say you fall off a ladder, typically we want to fix those cuff tears within 2 to 4 weeks. And studies have shown that patients have better outcomes and there's better healing the quicker you get to a traumatic rotator cuff tear. Okay, the reason is that typically the traumatic ones, once they tear off, they almost spring, they retract considerably. So if you wait too long and there's a significant amount of retraction, the tendon will start to fibrose and scar into wherever it tears. So if you wait, even I've seen in 3 months, you try to bring it back, there's a lot of tension on the repair, outcomes start to go down, and the patients are at a higher risk of re-tear. Most partial thickness cuff tears can be treated conservatively initially, and then obviously the non-dominant shoulder as well. So operative, all traumatic full thickness cuff tears, we recommend surgery for. Full thickness tears in physiologic young and active patients, and then obviously cuff tears not responding to conservative treatment. So in terms of our conservative treatment, so the things you want to work on is range of motion exercises to improve the patient's range of motion, to stretch the capsule. The most important part is scapular stabilizing exercises and rotator cuff strengthening exercises. This is important because, again, this all comes back to the balanced force couples. Okay, when the tendon is torn, that abnormal movement, by stabilizing the scapula and strengthening those muscles around the shoulder, okay, you can improve that abnormal kinematics and improve the abnormal contact, resulting in less pain. Heat therapy, and then you can also consider steroid injections, although this is not preferred. There have been some studies that shown the deleterious effects of cortisone injections. The reason is that cortisone is catabolic. It's softened, can break down tissues. So as the tissues are exposed to cortisone, it essentially can result in further, number one, softening the tendon itself, and then propagating the tear, making the tear bigger. Okay, and the aims are to control pain, restore the scapular kinematics, the scapular motion, restore the force couples. And typically I recommend a trial of therapy for 3 to 6 months of conservative treatment before electing to operate. I think 6 weeks is a little bit too soon. I don't think patients can get adequate therapy in about 6 weeks. And typically after about 3 to 6 months, if they're not getting better at that point, I'd recommend surgery. So this is a study that looked at the effects of intra-articular cortisone. Okay, so basically one injection led to alteration in the ratio of type 3 to type 1 collagen. Okay, type 1 collagen is a stiffer protein, and they showed negative effects of gene expression following cortisone injections. So in terms of physical therapy, a lot of my patients, a lot of people find it frustrating to do physical therapy. There's no quick fix with physical therapy. So a lot of patients, they don't typically put their best effort in when we recommend it, and oftentimes they don't believe in it. But the thing is, physical therapy works, and what's great about this study, they looked at subacromial pressures, okay, in vivo, in patients with suprascapular nerve block. Okay, so they basically did a nerve block to the nerve supplying the rotator cuff muscles. Okay, and basically subacromial pressures, they found that were affected by arm position and rotator cuff strength. Okay, so there's lower pressures with external rotation at the side. Okay, and patients with good external rotation strength were found to have lower subacromial pressures. Okay, so that's why it's important we have our patients do external rotation strengthening exercises when they are diagnosed with a cuff tear, and these scapular stabilizing exercises can decrease pain as well as pressure, the pressure effects in the subacromial space. So in terms of operative treatment, okay, if the patients fail conservative treatment, we typically will recommend surgery, and there's many different ways in terms of technique that you can perform a rotator cuff repair. I'm going to kind of talk to you a little bit about it. So, I would say about 15 years ago, I would say most surgeons were doing open. It was kind of 50-50. We're doing a mini open incision versus arthroscopic. I trained at an institution called Curlin and Jobe in Los Angeles, and they pioneered something called the double row repair. Okay, and we're going to talk a little bit about that today and what that is. And in my opinion, the double row repair has really kind of revolutionized how we fix these repairs, okay? Anything in orthopedics, it's all about recreating anatomy. It's about placing anatomy back to where it is for enough time for the body to heal. Once the body heals, our implants, our sutures, screws, whatever, they don't really matter anymore, okay? But the stronger fixation that you can get while also allowing the patient to move is really the goal of our repairs. Reason is that I can do a repair and I can keep the person in a sling for 3 months. It's gonna heal, okay? But the other effects there's so many other negative effects from immobilization of that extremity, of that shoulder. So the stronger the construct, repair construct that I can make while also getting the patient to move quickly is of tantamount importance in terms of having a successful outcome, okay? So to achieve okay, so we talked about that, okay? So essentially, this all allows for a faster recovery, okay? So what is the single row versus double row repair? So if you can see on the left, we refer to this as a row of anchors, okay? So you can see these suture anchors, these 2 anchors right here, okay? This is referred to as a single row. We place an anchor in the bone, and there's sutures attached to those anchors, and we basically pass the suture through the tendon, and then we repair it. We tie a knot and repair it that way, okay? And if you can see in contrast to the picture on the right, you can see that there's 2 rows of anchors, okay? There's what we call the medial row, where the sutures are passed through the tendon, the sutures are tied, and then instead of cutting the ends of the sutures, we actually take those sutures and we place them into a row more laterally, okay? And the difference is, as you can see, is the configuration of these sutures. On the right, you can see the cross configuration of these sutures allow for more surface area compression of the actual tendon, okay? So that extra surface compression allows for a better surface area for actual bony healing of the tendon into the bone, okay? And it also allows for a stronger construct, which actually allows us to move the patients much quicker, okay? So if you could see on the right versus the left, you're more likely, if the tissue's poor, the tendon can actually start to tear through these simple single sutures versus this double row. There's much more compression of the tendons, the bone, which is less likely you're going to get that tear through or the pull through of the tendon. Okay, so this study was done out of Carlin and Job, where they looked at repair site integrity after a suture bridge, and the patients did extremely well. Okay, 88% had an intact cuff at 1 year. And this was done for small to massive tears, and 76% of them returned to work. Okay, and none of the work comps retore. Okay, so I'm going to kind of show you a surgical video. So this is the actual surgical technique. This is the patient we saw earlier. So this is what we're doing here. We're essentially cleaning off the footprint, removing any residual torn tendon. This is important. It's important to what we call decorticate this area to allow for some bleeding marrow. That bleeding marrow is essentially going to help improve healing from the tendon-bone interface. So what we do is we place an anchor in the bone, and then we use this device. This is called a scorpion. We essentially sequentially pass these sutures, and then you can see that there's a pulley, there's a suture there. What we're doing is we're tensioning and pulling on that suture to bring down the tendon on the medial footprint. So right here, you can see this is the medial row. And now we're going to take these sutures and place them into our lateral row. And you see that cross configuration that we talked about earlier. So you can see this tendon is well compressed circumferentially all the way around. Okay, there's no gapping of the tendon. There's no lifting off of the tendon as I rotate the arm. That's important because you want, anything in the body, you need immobilization and compression to heal. Okay, so you want this tendon well seated and well compressed onto the bone. You can see that there's good contact throughout the entire tendon to bone interface. Okay, so let's see how these patients do. Okay, so this is what that construct looks like. You have your medial row, and then we take the tails and place them into a lateral row, and you get that cross compression. Okay, so this is that patient, okay, following the repair. All right, go. Good. Bring it down. Good. Bring it up. Good. Bring it down. How far away from surgery? 30 kilos. Nice. Bring it up. So this gentleman's about 4 weeks out from his repair. Prior to surgery, he could not lift his arm up above about 90 degrees. Okay. In the past, even when I was training, when we were doing single rows, these patients typically would take about 4 months to get to that amount of range of motion. We would be keeping them in the sling for about we typically keep them in a sling for about 6 to 8 weeks. Now I get my patients moving at 3 weeks. Okay, I think it's really important to get them moving right away. They have less stiffness, less pain, as long as you reliably trust the repair construct. So this is a gentleman, another one. He had acute traumatic rotator cuff tear. You can see right here. This is on his MRI. This is the tendon that's completely torn off. Okay, and this gentleman had what's called pseudo paralysis. Okay, where he just essentially could not lift his arm up. Okay, too much of the tendon was torn from the bone, so it was almost like he was paralyzed. So that's the same in the pre-op. All right, bring it down. All right, bring it up as high as you can go. All right. Oh, his poor face. He looks so dejected. All right. So this is that patient's surgery. So you can see here on the left, there's the tendon. He almost has an L-shaped type of tear. And on the right, he's got a large, massive tear. So you can see that whole tendon tore off the bone there. The same thing. These are the anchors that we place on the medial row, anchors going into the bone. There's our second medial anchor going in. Okay, so what I'm doing here is I'm pulling the tendon back to its native anatomy, and I pull on these 2 sutures and essentially pulls these tendons and compresses them down to the bone. All right, and now we're placing our lateral row, and then again, this is our cross configuration. This is a nice kind of depiction. I'm pulling, and you can see the tendon getting beautifully compressed to the bone. And then same thing, you see that kind of circumferential compression. Every part of the tendon is well compressed to the bone. There's a nice just interface there. And then this is that patient. This is him 14 days post-op, that same patient. All right, how long ago was your surgery?
13 days.
All right. So you can bring your arm up. All right, bring it down. Bring it up one more time. All right. And then this is him at 6 weeks.
Okay, we can go.
Get down. Good. How far are you from your rotator cuff repair?
Well, that's 6 weeks. Practically, I've been doing pretty good.
All right, this is another lady, 6 weeks.
The side,
Bring it up,
to the side, I can
Bring it
go
up.
up.
bring it down. Good, bring it up. Good, how far are you? How far are you from surgery?
2 months.
Bring it down. Amazing.
You're great.
And this is the same person. I
So
actually
did
did a
the reverse
replacement on
total
her
shoulder
left side,
and let's see the
and then
right.
I did a
from the
rotator cuff repair on the right.
Good.
Just full motion.
Show, let me see.
How about this?
These patients do extremely well if you really take care and you have a really good construct and you have so strong fixation, good construct, and you get them moving quickly. And that's really the name of the game, and that's how you really can improve their outcomes. Okay, so what do we do when the rotator cuff is irreparable? Okay, so typically patients, we talked about the dynamic force couples and how the tendons are balanced and keep the ball seated in the head. Okay, so if you have a massive rotator cuff tear, the shoulder actually goes through these adaptations. Okay, and one of the things that happen is you get kind of what we call migration of the humeral head. You get proximal migration of the humeral head. So because the cuff tendons are no longer balancing and keeping the ball in the socket, the ball just starts to migrate upwards. Okay, as the ball migrates upwards, okay, you start to get abnormal point pressure on the ball and socket joint. Okay, we're like cars. If the cars are a little bit out of alignment, you start to wear your tires out a lot faster. Same thing in the human body. If you're out of alignment, things start to wear faster because there's point loading on the cartilage that's abnormal, and there's not kind of that diffuse continuous pressure throughout the cartilage. So that point loading, you start to get rapid degeneration and you get arthritis and you get something called rotator cuff arthropathy. Okay. So you can see the x-ray on the right, you can see this ball, okay, the humeral head is no longer well seated in the socket, it's migrating upwards, and it's actually articulating with the undersurface of the acromion bone, okay? So in France, okay, they basically, okay, pioneered a surgery, okay, where they figured out that if you do a shoulder replacement and you actually reverse the configuration, okay, you put a ball where the socket is and you put a socket where the ball is, you actually change the center of rotation of the shoulder, okay? And as you change the center of rotation of the shoulder, you actually no longer need your rotator cuff to lift your arm up. You can actually, you actually make the deltoid more efficient, and the patient can now lift their arm overhead with this prosthesis. So if you could see on the left, this is your classic anatomic total shoulder replacement, where you can see there's a ball where the ball is and a socket where the socket is. And then on the right, you see the reverse. We put something called the glenosphere on the socket, and then we put a cup on the humeral side. Okay, and this image over here kind of depicts what goes on. So you can see the center of rotation is over here in the normal shoulder. As we reverse the configuration, it moves the center of rotation over, and you can see here the deltoid increases in length, and now the deltoid is tensioned enough. It's almost like biohacking to bring the arm up. Okay. So with reverse total shoulders, it is a newer procedure. We've been doing it consistently for about 20 years. One of the issues we have with the reverse total shoulder is that if you go back and look at the prosthesis, this is your typical component on the glenoid on the socket side for a regular total shoulder. With a reverse total shoulder, you see how this glenosphere almost projects outwards. Okay, that projection, okay, essentially increases the lever arm on the prosthesis. That increased lever arm actually places a lot more forces on the interface between the prosthesis and the bone. Okay, it's almost like putting a diving board outside that bone. The issue comes in is that the socket itself in the scapula is a very thin bone with a small little projection of bone for the socket. Okay, if this component loosens, That's it. We've burned bridges. There's not much bailout. If a patient's had a reverse total shoulder and this thing starts to loosen, we essentially run out of bone stock to put another one in. It's not like the pelvis where a cup loosens in the pelvis and there's plenty of bone to find fixation to put screws. But one of the biggest problems we see with this prosthesis is that when it loosens, it's a disaster. So we typically do not like putting these in young males. 50, 60-year-old males, it's too young, especially if they're active, especially if they're a laborer, because cycling repetitively in that area, these things will loosen. And if they lift heavy, forget it, it's going to get loose. So one of the things that has improved the outcome of this surgery is patient-specific planning, and it's something I've incorporated into my practice. So essentially what we do is with commercially available technology, we get a CT scan of the patient's shoulder prior to surgery. I then submit that CT scan to a vendor, and that basically gets put into a computer. And then on the computer, I basically have a surgical plan. Okay, and with that surgical plan, I could actually dial in exactly where I'm going to put the prosthesis, and I can elect to make sure I put the prosthesis in the area which we refer to as the vault. Okay, the vault is the small kind of area of bone that has the best bone, okay, for fixation. So once I do the plan on the computer, the company, and I confirm the plan, the company will then 3D print these models, patient-specific models, that I will then use in the OR to put the prosthesis exactly where I planned prior to surgery. So this is what it basically looks like. You can see the plan here on the right. You can see that I'm essentially planning to place, you can see this blue screw on the top. Look at this small corridor of bone I'd have to get in to get this screw correct and right. See that? I can do that preoperatively on a computer and know I'm getting it in the right place. In the OR, you can imagine the socket is about this big. You have all the muscle around it. Okay, it's nearly impossible to get this right every time. But with this technology, it really has changed the game in terms of how we're able to really plan and get things right the first time, especially on a surgery like this, where there's a lot of bridges you can burn quickly. So this is essentially what it looks like. So the company on the top right, they'll actually give me a 3D printed model of the patient's socket and glenoid. And then they'll give me this actual guide, which I'll place onto the glenoid itself at the time of surgery. And then I put these pins to know I'm in exactly the right place. And this is what it looks like. This is a guide for a patient's shoulder. This is the guide as it comes on. And then, so let's show you a case. So this is a 68-year-old female with longstanding right shoulder pain and weakness. This is her x-rays. So she's got bone-on-bone arthritis. We got an MRI. Showed she had a full thickness rotator cuff tear. She had weakness. So she was indicated for this. This is a perfect indication. She's a female. She's 68. She's a great candidate for it. So this is an intra-op depiction of how we use the 3D printed guides. Okay, so what I'm doing here, I'm in the OR. I'm looking at the socket. I'm looking at the patient socket to make sure it matches. And then I place the guide on the socket. Okay, so this guide is going to make sure the screws are going to go in the most amount of bone in the vault. Great with these, it gives you a certain amount of confidence. So what I'm doing here is I'm checking to see if these holes that I place my pins match the holes on the guide that I planned. Okay, and you can see here, just based off the contour, it's exact. So I know the pin's in the right place. I'm happy. So then now I'm essentially reaming and preparing the socket, okay, for placement of the prosthesis. And then now we place our final This is the base plate, which we will secure the actual glenosphere prosthesis to. All right, so this is that patient. Okay, this is a post-operative x-ray. Looks really good. I have great screw lengths here. I was able to get really long screws. And this is that patient at 12 days post-op.
Levanta la mano, levantar el brazo para
As high as you go.
lo más que puedas. Ahí voy.
Bring it down.
Ahora bájalo.
And bring it out to this side.
Ahora para el lado. Ajá, para este lado.
Okay, good. And bring it down.
Y para abajo, bájalo.
Bring it up in front of you.
Ahora al frente, ven al frente, mira. Así. ¿A ti? Aquí, sí, sí, sí.
All right, is that same patient at about 8 weeks.
Good. Bring it down.
Bajo. Baja.
Good. Bring it up.
Subiendo. Ajá.
Great. Now bring it down.
Bájalo.
All right.
I think I have one more case to show you guys. So last case, this is a 76-year-old male. He had severe rotator cuff arthropathy. So he had actually some of the biggest deformities I've ever seen. So you could see here, this is the ball. This is the socket. You can see his ball is migrated all the way upwards. He's had this for so long. You can see his acromion bone over here is almost like a potato chip. It's so thin. He's been rubbing in that area. He's rubbed so much of the bone away. Okay. He's also he's asymmetrically worn his socket down significantly. So this was a perfect case for it because he was missing so much bone that I had so much less of a vault to deal with. So this is a perfect case to use this type of technology because it really does improve your intraoperative confidence that you're putting everything in the right place. So this is the same thing. This is him.
Specifically on reverse. Specifically on reverse.
All right. This is post-op x-rays. Looks really good, really happy. Screws are coming right into the vault. Everything looks really good. So this is him at 12 days post-op.
Excellent.
And then this is him at 7 weeks.
Fast. Too fast. Bring it down. Go slowly. Okay. Go slow. Bring it down. Good. Bring it over your side.
All right. All right, that's it. Thank you. Do you guys have any questions?
Well, Doctor, while we get some questions, I want to thank you. That was amazing. And as technology, I'm so amazed how everything has changed, right? But
Even the last 10 years, it's pretty unbelievable. You know, I have a lot of patients that, you know, they come to me and they're like, oh, I heard it takes about a year to recover from a rotator cuff. And you know, in the past, that used to be the case. But the way technology's improved and you know, by getting, like I said, better fixation, you get patients moving a lot quicker, they recover so much faster. And it really has a positive effect on their outcome.
I had a friend of mine that we were in Cancun one time, and he decided to body surf, and he didn't know what the hell he was doing, and the waves crashed him into the sand, and so they really couldn't do much for him. He was younger; he was 30-something years old, but then they just had him doing bicycles with books, and obviously doing weights to strengthen, like you said, the scapula. But I mean, just watching everything gone by, and can you talk a little bit about the psychology of movement, right? I mean, did you see their faces? You pointed it out. That guy's face, and then when you got him to where another movement, his face. Can you talk a little bit about that? Because we always think about the surgery, we think about the rehab, but the psychological component on that patient, and we always like to think of the lifetime value that we provided to that patient. Can you go over a little bit of that?
Yeah. So I tell my patients, I tell even like my staff, my patients, there is 100% a psychology to recovering in general. And it's interesting. I really do try to take the time to get to know my patients and get to know their nuances and the things that make them anxious, the things that are important to them, because oftentimes you have to take that into account as well. I have some patients that they don't feel pain and they don't have any fear, So patients like that, I actually, I psychologically, I keep them immobilized a little bit longer. The reason is because I know they're moving on their own. I know they're doing a lot more. If you get people who are like that, who don't really feel a whole lot of pain, and they're just, type A personality, ready to go. That first patient I showed you, who's wearing black, he's that patient. He had torn his rotator cuff. He told me he's going to China to go on some hike a mountain and then come back afterwards to do the surgery. I mean, this guy's tough, and he had pseudo paralysis, inability to lift his arm. I'm like, why are you going to China to hike a mountain? You can't even move your arm. But a patient like him, I had to slow him down. I had to tell him, because he was like, in 3 months, he wanted to surf. I was like, no, you can't do that, sir. But on the other side, on the other token, I have patients who are just incredibly anxious, and they're super hyper worried. There's those patients are the patients I try to get them moving. I try to reassure them quickly. I tell them, listen, you got to get moving, take the sling off, because they're the patients that they sit in bed all day with the sling, and they want people to bring them food, and they don't want to move, and they're hyper scared. And those patients have a tough time because they get very stiff. And they progress a lot. It takes them a lot longer to progress. So there's so much of a psychological aspect. I can do the same surgery on 10 people with the same exact tear, and I can get 10 different outcomes based off of the psychology of the recovery process. So to me, it's one of those very important things you have to really keep in mind.
I thought it was strong when I had ACL surgery, and then they sat me down to do rehab, and they were just pushing my leg forward. I was lying down, and I felt like my heel was hitting my head. And then I asked, how far had you gone? And they said 5 degrees. So it is, you're so right.
You've been through it. It's tough. It's tough. And especially in the beginning, you lose your independence. These injuries are very painful. It's definitely tough.
You have a question here. It doesn't say where it's from. It's anonymous, but it said, do you have specific rehab protocols for the different types of injuries, right? But rehab's huge for us, right? Everything you all do, you're supported, and I think maybe you can talk about how your approach is at your what your team does as a total team approach. Can you go over that, different than somebody just working on their own?
Absolutely, yeah. So like you said, rehab is everything. Like I said earlier, I can do 10 of the same surgeries, and everyone has a different outcome. And a lot of it has to do with their psychology and the rehab. The surgery is actually, I tell them, the surgery is the easy part. So I have 2 different protocols that I use for my rotator cuff repairs. I typically will decide which protocol the patient gets after the surgery. There are certain parameters I look at. So number 1 is tendon quality. How good is the tendon quality? If it's very thin, okay, or if the patient's had repeated cortisone injections and I'm worried about the tendon cutting through, I typically will keep them in the sling a little bit longer. And so I'll typically keep them in the sling for about typically 4 to 6 weeks. I have a rapid rehab protocol, which is the one that you saw some of the patients go through there. Those are the ones I'll do if there's good tendon quality, there's not too much retraction, and there's not too much tension on the repair. Those patients, I'll do the rapid rehab protocol, and those patients, typically, I'll get them moving at around 2 to 3 weeks with passive motion, and at about 3 to 4 weeks with like active assisted range of motion.
Thank you, doctor. And you all see some complicated stuff, because doing taking care of some of these sports teams and everything you do, there's a lot of complicated things you see. But we're known sometimes more as a tertiary referral center for difficult ortho. Can you talk about, again, when you're having a secondary surgical attempt. Somebody already had something done, and then you got to come in after. And I see many insurance companies might not send it one place first, and then they want you to save the world later on, and then they wonder why, why is it so hard to get it done, right? Can you go over a little bit about about those secondary attempts to fix something?
Yeah, practicing, I've been fortunate if I've practiced in major cities, I New York, Los Angeles, and now here in Miami. And I would say practicing in Miami, I definitely do see the most complicated cases because a lot of them are international. I mean, this is an international hub of the world. So we see a lot of that. And patients that have had revision surgery, it's much more complicated. There's a lot more things to take into account. Patient's biology, for instance, you have to start to ask yourself, why didn't this patient heal? Is there something underlying? Is the patient a smoker? Is there a diabetic? Sometimes I'll actually get pre-albumin levels on them just to make sure that they have good nutrition, especially some of our patients that come from developing nations. I think all those things you should take into account, make sure that they have a good nutrition status. And the intraoperative, there's numerous intraoperative considerations to take into place with, scarring, healing. A lot of patients have implants that they're coming from international places, implants we're not familiar with or we don't use here in the United States. So it's definitely we definitely enjoy it. I think all of us that are on staff here enjoy taking on those more complicated cases. I think it's kind of just part of the orthopedic department here at Baptist, is that we're all everyone's very excellent and very capable of taking care of these very complicated cases. So yeah, it's one of the kind of more enjoyable things, and that's why I really enjoy giving these talks and reaching out to my international peers, just to kind of get some of for them to have an opportunity to get to know me and see what we do here. And if they do run into these cases in their communities or in their practice, they can feel comfortable sending it to us and know that we're going to take good care of them.
Sorry, I'm on mute. I have a question here from Jose Hernan Rojas, who asks, what are the post-op outcomes for patients who used to lift weights regularly? Will they be able to establish rotator cuff integrity in order to do that?
Let me read that question.
What are the post-op outcomes for patients who used to lift weights regularly? Will they be able to reestablish its rotator cuff integrity in order to do that?
Yeah, depending on the type of lifting that the patient does, one of the things I do recommend in patients who do have, I have a bunch of heavy lifters in my practice who've torn their cuff, and I let them, they majority of them all go back to lifting. Some of them are psychologically traumatized by the surgery and the recovery, that they decide that, oh, maybe I'm not going to lift as heavy and I'm going to do more kind of isometric exercises and work with a lot more bands. But I don't restrict my patients in terms of going back to doing that heavy lifting. I let them, do whatever they want to do, but at the same time, I do try to have them avoid lifting heavy overhead, okay? Because that places you in an impingement position, and it could further kind of abrade the rotator cuff that's previously been repaired on the undersurface of that acromion bone. But things like bench press, biceps, most triceps are fine. I get a little bit concerned if they're doing a whole lot of heavy lifting overhead, but for the most part, I let them get back to doing what they're doing, and majority of them do well.
I've had to do a lot of air ambulance transfers on patients that had pelvic situations that got post-operative infections, and then we got to start all over again. Can you go a little, do you see a lot of that in the shoulder on yours, from coming from different places, and how do you deal with them when you get them?
Yeah, I don't see a lot of actual infections, post-op infections. The good thing about rotator cuff repairs and any arthroscopic procedures is that the infection rate is exceedingly low. And the reason is because the entire surgery, we're actually pumping water in and out of the shoulder constantly, and the incisions are very small. So fortunately, we don't see they happen, But we don't see any infections that come from overseas over here, thankfully. But I do see a lot of patients who've had previous failed cuff repairs, patients who have irreparable rotator cuff tears, that some of them we like to do like the reverse total shoulder arthroplasty on. One thing I commonly do see in the shoulder are malunions, malunited fractures that healed in a bad position. But for the most part, as it relates to shoulder, the two things I see the most are shoulder instability, patients with recurrent instability, and massive cuff tears. Most of the cuff tears I get from internationally are not small. They're all pretty big.
So for any GP that might be on this call, any recommendations for a GP that has somebody walking through the door and you're not sure and you don't have an MRI, but you got to do an X-ray? Any recommendations for the GPs or any internal medicine family practice physician that might not have access to a CT right away or an MRI? What are we looking for?
So a couple things you want to look for. So number one, take a good history. Pain at night, that's the biggest one. They're typically, you rarely see cuff tears in, degenerative cuff tears in 30 or, 30s and younger. Typically 40 and older are going to be more at risk for rotator cuff tears. And then in terms of the physical exam, there's 3 important tests that you want to do. First one is called the empty can test. Okay, so basically you bring your arms like this in the scapular plane with the thumbs down, and then you're going to push on the patient's arm and to see if they can resist you. Okay, if they're doing the empty can and the arm drops, that's actually a positive sign for a supraspinatus tear. Okay, and then the next one you're going to have them do resisted external rotation. I don't know if you guys can see me. So you're going to have them essentially bring their arms, okay, to the side like this and have them hold it. And then you're going to push and you're going to see if they can resist you. If the arm goes this, okay, goes to their belly, that's a full thickness infraspinatus tear without a doubt. Okay. And then the last one you're going to do is something called the belly press. Okay. With the belly press, it's testing this subscapularis tendon. And what you're going to do is you're going to have them put their hand on their belly like this, and then you're going to have them bring their elbow forward. Okay. A positive test is this. The patient's going to go like this, and they're actually going to lift their wrist off their belly. Okay. They essentially start to do this because they can't internally rotate their arm. By putting your hand on your belly, you're actually internally rotating the shoulder. You're bringing the shoulder this way. And if their hands on their belly and you tell them to, their hands on their belly and you tell them to touch your elbow here and they start doing this, they're lifting off, that's a positive test. They have a torn subscapularis. With the physical exam alone, I pretty much the majority of the patients, I diagnose them with exam alone before I even get the MRI. Those three tests are very specific for rotator cuff tears. Now, they'll have a lot of other things can cause pain during those maneuvers, but it's the weakness that is pathognomonic for those tears.
Thank you, doctor. And you got greetings from El Salvador and many blessings. And they were saying thank. So I think it's amazing, and I think one of my attendings or one of my dean of medical school told me that asked me what is the best type of doctor. And I said, I don't know, a cardiac surgeon, neurosurgeon, I don't know. I was still a young medical student. And he says it's the one that knows when to refer. So I'm glad we know how to get to you now. And if anybody needs any help getting to Dr. Lerebours, you have a whole team at Baptist Health International to be here to help you. And with that, on behalf of Baptist Health International, I'd like to thank Dr. Frantz Lerebours for his informative presentation and all of today's participants for your attendance. If you have any additional questions about today's presentations, please feel free to email us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will make sure to get them to the doctor. If anybody would like to also connect with the doctor and has any particular questions or would have any patients they would like to discuss with Dr. Lerebours, I can tell you right now, he is always available. Great person to work with, and just reach out to us. We'll connect the dots we will be your AT&T operator to the world. And so we look forward to seeing you at our next Orthopedics and Sports Medicine lecture series scheduled for Wednesday, September 11th, 2024. Thank you again and have a great afternoon. Thank you, Doctor. Fantastic.
Thank you, guys. It was a lot of fun. I appreciate it. Take care.
Take care.